Done.
Thank you. Okay, Tess, take it away. Thanks for being here.
Yeah, thanks. Sorry, I'm trying to get, hold on. These boxes, I'm gonna unshare my screen for just a second because I can't get this. My mouse is not visible when I'm sharing my screen, so I'm trying to get all the boxes out of the way so I can see my screen. Oh, there we go. Okay, sorry about that. Okay, so the first topic that we were going to walk through for our Women's Health Day was going to be a talk on breast cancer screening. So I was going to talk through breast cancer screening and really focusing on how to, like really a guide for the primary care setting, since that's where most of us as residents will be talking with patients about breast cancer screening. So the objectives for this are to identify important risk factors for breast cancer development, take an appropriate breast cancer family history, integrate a stepwise approach into developing breast cancer screening plans, and understand the risk calculators and when to use them, and then finally just correctly assigning patients into the risk category that makes the most sense for them. So first, let's just get some basic breast cancer facts out on the table before we begin. So breast cancer is the most common cancer in women worldwide. The fact that the stats that we often get from SEER data is that 1 in 8 US women will develop breast cancer across their lifetime. It's the second leading cause of cancer mortality in the US, second to lung cancer. And mammography has been shown to reduce breast cancer mortality and morbidity. So by morbidity, we just mean that it detects cancers earlier. And so patients need less invasive treatments and therapies. And so they have less morbidity and mortality specifically related to breast cancer. The other reason that breast cancer screening is really important is that the results that we get from it are actually quite actionable. So when we talk with patients about their risk and we assign them to the correct group, we can think through a more appropriate timeline for their screening. When we talk with them about their risks, we can also assign or get them referred to genetic testing. And certain patients who fit into the right categories can be offered risk-reducing medications and surgeries. So there are a lot of things that we can do to help patients reduce their individual risk going forward. Okay, so there's a lot of pieces of breast cancer screening and imaging that get talked about and thrown around. So I think before we really dive into all of the details, let's just make sure we have we're all on the same page about the vocabulary of what we're talking about. So there are a number of different ways to image the breast. The first one that I think all of us are familiar with is the mammogram. There are actually a number of different ways to do and order a mammogram. The ones that you're probably ordering and the ones that you've probably sent patients for are digital mammograms. There are screened film mammograms, but in the US, I think over like 98% was the number I saw yesterday, that most of the centers that do mammograms in the US are now using digital or digital tomosynthesis mammograms. The difference between, you've maybe seen these like digital tomo words written on the mammograms. The difference between a 2D digital mammogram and a 3D tomo mammogram is just that there are more images taken. So this means that patients are actually getting a little bit more radiation, but it's something that the SCCA and UW centers here mostly do, just because it does give you a better picture, and it can reduce the amount of false positives and recall rates. So after the mammogram, there are other ways to image the breast. Of course, there's breast MRI. We can do an ultrasound of the breast. We'll get into the details of why and when we would consider using those things, but generally, they are not our first line options for just screening. There are also ways to do breast exams. So clinical breast exams, patients often, ask about their annual breast exam when they come in for their visit. We'll talk more about that later as well. And then there has been over years past a lot of talk about patients doing their own self breast exam. And so we'll talk about that as well. But just to put it out there, there is a difference between screening and diagnostic imaging. if any patient comes in with a concern about their breasts, so if they sensed a lump or they notice there's nipple discharge or anything that is abnormal to them, then, and if you feel that there's something that is worth looking into more, that would be a diagnostic image. So you would, that would be a whole separate conversation of, if you would do a mammogram, a diagnostic mammogram versus ultrasound. But the screening is what we're going to focus on today. Okay, so our first patient has come in with a question. She says, I heard my birth control can give me breast cancer. Should I stop taking it? This is a great question to start out with because actually Nina is going to talk to us more about birth control and its risks for various cancers as well. But to get to that question, I think first, let's just start. There are a lot of different things that get thrown around as affecting the risk for breast cancer. So I hope that this works out well, but maybe in the chat box, if people could just start saying, like, just type out what they think about when they think about breast cancer risk. Did you see? Okay. Family history of breast urine, prostate cancer, first degree relative, family history, biopsy. Great. Okay. Yeah, a lot of these are the common things that people think about. Age onset. Perfect. So I'm seeing a lot of comments about family history, some details about the type of cancer that people have in their family, details about the actual relative that is diagnosed. That's great. Parity, so how many kids people have had, prior biopsies. I see age, menarche, and then estrogen exposure. Okay, great. All of those things are super important to consider, and we can talk through a few of them in detail, but those are all some of the things that we would think about. So there are three kind of big buckets of breast cancer risks that we can categorize for patients. Some of them, the first group is personal risks. So this is just specific to the patient themselves. So if the patient has known mutations that put them at higher risk for cancers or breast cancer specifically, that's of course going to be an increased risk. Someone mentioned prior biopsy results. So there are a number of things that patients can, if they, did find a lump and they've gone through diagnostic imaging and then they have a biopsy that's done and they have been found to have atypical ductal hyperplasia or LCIS or lobular carcinoma in situ. There are a number of other ones as well, but those are things that we want to know as a part of their personal breast history, just because that can place them in a higher risk category at the outset. Other things like prior cancers or prior cancer treatment, specifically radiation therapy, is really important to know. Breast density is a personal risk factor and something that they probably won't know about themselves unless they've already had imaging done. And then age, of course, is super important as well. Family history is a really big bucket. We'll talk through actually taking a family history in just a bit, but things to think about are who was affected by cancers, what their age was, what their degree of relation was, what genetic risks are known in that family and their heritage as well. And then hormonal issues. So things like their parity of, which I think someone mentioned. So how many live births the patient has had, how old they were at their first birth, if they've been breastfeeding. If you have been breastfeeding, that can slightly reduce your risk. If you have hormone therapy exposure, so that can include hormonal birth control at different types of birth control and different ages that you're taking it and lengths of time you're on it can affect your risk. And then if you're on therapy postmenopausal as well, that can increase your risk. Age of menarche and age of menstrual, like when you start your menstrual period, those things can affect your risk. And then weight. So obesity has been shown to be an increased risk for breast cancer as well. So Age is one of the most important things for most women of average risk, unless we know that they have certain biopsy or certain mutations or family history. Age is really one of the most important things to think about, which is why age is such a big factor in deciding when we're going to start screening for patients. So just looking at this graph, we can see that the age, as age goes up, the number of breast cancers increases dramatically. We can go through this kind of quickly, but this is just talking about a few really specific personal or all different types of risks for breast cancer and their increased relative risk. I highlighted this one because it's such a high relative risk. It was 26 compared to women without chest radiation. And I think, sometimes we forget to ask patients about their own personal history of therapies, whether they've had cancers or not. A lot of focus on family history, but if patients have been exposed to radiation, we really want to think about the fact that they have a higher risk. Okay, so one of the things I mentioned was breast density. And so a lot of patients will come in saying, after I got my mammogram, I got this letter and it said that I had dense breasts. Is that normal? This is an important thing to talk about with your patients, and it can actually, be a great prompt for discussing breast cancer risk and screening in general. Breast density, there was a law that came out in January of last year saying that the facilities needed to notify women if they do have dense breasts. This, of course, brought up a lot of questions in clinic visits, but I think it's important to just emphasize that dense breasts are actually not uncommon and they're very normal. At the bottom, you can see in that picture, about 50% of women will be in the category of dense breast. The dense breast tissue can make it harder to find cancers, which is why it's just something that has come up as an important piece to talk about. There are some studies that can show it has increased their cancer risk as well. But we can talk more about how exactly to categorize these women who do have dense breasts and think about their screening. But just to emphasize that it is not an abnormal thing. About half of women are going to have some sort of category about their higher dense breast density. Okay, so there are a number of different guidelines and a lot of different societies that all have different recommendations about screening for breast cancer. And I think I certainly have struggled in the past to try and sort out just what I should be advising patients to do. And I think when we think about all these different risk factors, it's hard to know, should they be every year? Should they be every other year? When do we start? When do we send them for genetic testing? So this was actually a stepwise plan that Addie McClintock was a big part of making this this framework for thinking through how to put patients into the right category and screen them. So we'll just talk through that now. I think just in thinking about all these steps, I think the thing to keep in mind in the back of your mind is really that at the end of the day, what we're really trying to do is just appropriately place patients in the right risk category. So there's average, intermediate, and high risk. Most women are going to be in our average risk category. So that's what a lot of the guidelines and that come out from societies are really focused on, are average risk women. The average lifetime risk of breast cancer for most women is 12.4% across their lifetime. So we just, as we're going through these steps, just want to think about, moving patients through the steps into these different categories. Okay, so there are 4 steps. The first step would be assessing a family history. So a patient comes in and says, my aunt was negative on her genetic test, so I don't think I need to get tested. That's something that I feel like I've heard from a lot of patients. They just say somebody in their family was negative or positive. And at first it can seem like that maybe is helpful, but there are actually a lot of other layers and details that we need to get at before we can decide if that patient is at higher risk or if they need to get screened themselves. So let's just walk through how we would actually assess a family history. So the details are super important here. So asking patients, do you have any breast cancer in your family could be, one way to start, but we really want to get at all of the members in their family. And so I know this can be cumbersome for a short visit, but it can actually be a good reason to just have a full visit and talk about like health maintenance and screening for patients, because this can take a little bit of time. The best way to do this is to really draw out like at least a 3-generation pedigree for patients, with as much information as they have. Of course, a lot of patients don't know all these details, but just getting as much as we can is really useful. So if you start with that patient and then trying to sort out which family members were affected by what cancers, really taking all cancers into account, I think is most useful in the visit, just so that you have all the details, not just breast cancer, not just ovarian cancer. And then knowing the degree of the family member in relation to that patient, what side of the family they're on. And then other things that are important to know are if the patient did have breast cancer, is if it was unilateral or bilateral, because if patients have had breast cancer on both sides, that actually will count in our risk calculators as 2 different cancers that developed. And it's also important to think about how many patients are in this family, or how many people are in this family that aren't affected. So if this is a family of 8 people, for instance, and only 1 developed breast cancer, that's potentially a different situation than if there are 2 people in the family and 1 developed breast cancer. So important to get all of those details. This is just a pedigree to just get a sense of when we talk about 1st and 2nd degree or 3rd degree, mother and daughter and sister would be 1st degree, but then anybody beyond that, like maternal grandmother, maternal grandfather, all of those members would be 2nd degree. And then 3rd degree are people even 1 more removed. But just a little review on how pedigrees work. Okay, so when we're assessing our family history, once we get all of those details from people, there are tools that we can use to decide if they are, if they have any of the boxes that we want to worry about for higher risk. So the USPSTF and the NCCN both have tools that we can use to assess this family history and put those details into context. I'm not going to go through one of them right now, just because they're a little bit it's a bigger list of things, but I think the thing to know is just that the NCCN tool is a little bit broader, so it actually will include details for more cancers, not just I think the USPSTF tool focuses more on BRCA associated cancers, which either one is fine to use, but if you once you have that detail, you can use those tools. And then if nobody in the family has a risk for this, you just move on to step 2, where you're just going to talk about personal risk. But if you get this information and you find out that they are positive or they do have family risk, then you would refer them for genetic counseling. And this is, if you look into the NCCN guideline, that's where you can find one of their tools. And then you would send patients for genetic counseling. And once they get their genetic counseling, they will, of course, decide if they're in a higher risk group or what their risk actually is. If you go through the tool and then it doesn't actually refer them to genetic counseling, or it doesn't really assign them higher risk, then you can go back to step 2. Okay, so moving on to step 2, so assessing personal risk. This is where we want to get all of the individual information from patients, thinking about those prior slides when we were looking at parity and hormonal risk. So assess their age, their weight, their hormone history, birth history. If they know anything about their breast density, that's helpful. And then, of course, if they've had any cancers or biopsies themselves. Things to think about that are going to automatically place people into a high risk group are going to be things like the LCIS and atypical ductal hyperplasia that we mentioned before, chest radiation, and if they themselves know of a personal risk mutation or high risk mutation, then all of those things, if they have even one of them, they just automatically go into a high risk group. Otherwise, if they don't have any of those things and they just sort of have a mix of a baby born at this age and they took birth control when they were in their 20s and they had their period at this age, all those different details we then use when we're thinking about their prediction, when we're going to think about their risk models. So then moving to step 3, we now have all of our family history and we have all of our personal information about the patient. So then we can place all this information into one of our risk prediction models. So there are actually 3 of them that are used, and it can be a little bit tricky to decide which one is right and which one makes sense for that patient. So I think we'll just quickly go through all of the ones that exist, and then you can learn a little bit more about which one might be the most useful for you in practice, and then which one might be useful for certain patients. Okay, so the three that exist are the GALE, which is the National Cancer Institute model. It was the first one that was made, I think. And then the BCSC, the Breast Cancer Screening Consortium model. And then the third is the Tyrer-Cuzick, or IBIS. That one is the most cumbersome, but we'll talk through all three. So the first one is the GALE model. It is the first one that was created. It's always used as much now in primary care setting, just because it's not great for actual discriminating individual risk scores. It has pretty limited inputs. It doesn't include a lot of family history. It doesn't include a lot of personal history. So it's not it doesn't grab a lot of info about that patient, but it is something to I included the link here, and you can click through it if you want. But it's something that is used a lot when they were thinking about patients getting risk-reducing medications, so things like tamoxifen or aromatase inhibitors. And if patients are going to be started on those, this can be an important tool to think about. We'll talk about the BCSC briefly. This one is actually the one that I think is maybe most commonly used, or is just easier to use in clinic. The things that it can be helpful for is that it does focus, or has a question about breast density. So you can include that if patients are coming in with questions about that. It does have limited family history as well, but it has a pretty diverse group of people that it was based off of. So it can be good to use for primary care setting. I'm just going to click on, I hope this doesn't mess up anything, but I'm just going to click on the link. Okay, so if you can actually just type in BCSC, you can Google it and try and find this, but BCSC has a number of different tools for breast cancer screening, but this is all it is. It's just one page, 6 questions. It's pretty quick. We can just kind of walk through. Oh, it's not? Oh. What does that mean? Share. How about now? Yeah. Oh, okay, great. Glad we're doing this in the same room. Okay, so this is just the link that was included. So you can write the link down if you want, but you can also just Google BCSC, and you can find a bunch of their different tools. So it's pretty short. So you can even go through this like right after your visit or with your patient if you want. But just to kind of click through things. So does this patient have a history of breast cancer? Let's just say no. Let's pretend this patient is 46. And she'll be white, and let's say she has no family members with breast cancer. She has not had any prior biopsies, and we'll just say she's heterogeneously dense. Okay, so we'll calculate risk, and this is what it will pop up with. It tells you your 5-year breast cancer risk and 10-year breast cancer. Of course, these are estimated, and then it will also tell you here what this woman's average risk would be. So if all things were equal for this woman at the same age and race, this would be her 5-year risk, and this would be her 10-year risk. So you can just see, this was a made up person, of course, but what they are compared to average. Okay, so new share. Let's go back. That's good. Okay, great. Okay, so that's the CSC tool. I think that one is a good one to keep in your back pocket just because it's pretty useful for most patients, especially about breast density. And then the last tool that we'll talk about is this Tyrer-Cuzick model or tool. And so this one is a very detailed tool that you can use. It takes in a lot more input, so a lot more personal information, a lot more information about family history. So I think the two things about are really the BCSC and the Tyrer-Cuzick models. If this patient has an extensive family history, like they have a lot of members in their family and they have many different cancer histories, different ages, different diagnoses, different sides of the family, it's really going to be important to use this one because you can actually put all of that data in, whereas the other one, BCSC, will only include the first degree family members. It's a little bit more time consuming. You have to answer a lot more questions, but if this patient really does have that many people in their family that are affected, it's an important thing to go through. So, and this one also can give you lifetime risk, not just 5 and 10 year as well. All right, so once we have selected which risk prediction model we want to use, we put in all the information, and then we get the 5, 10, or lifetime percent risk of breast cancer. And those are the numbers that we're going to use to decide if the patients at the end of the day need to be in average, intermediate, or high risk category. And just to say again, that's really the goal of this whole stepwise approach, is just deciding where they belong in this average to high risk scale. So for our patients who are high risk, let's just talk through, there's a little bit less back and forth and controversy about what those patients, how they should be screened, whereas for average, it's a little bit more complex. So we'll talk about high risk first. So our high risk patients are, just to talk through who exactly we're going to be considering high risk again, people with known genetic mutations, people with personal breast cancer, high risk lesions, if they've had previous radiation, and then the cutoffs for those scores that we were talking about, a lifetime risk of over or equal to 20%, and a 5-year risk of over or equal to 2.5%. So anybody in this category, we're going to be thinking through high risk guidelines. So there are a number of societies that have come out with guidelines for high risk women, ACR, which is the Radiology Society, and NCCN. And there seems to be a pretty decent consensus around plans for this. So if you are gathering your risk score for this patient, or if you're deciding this patient is high risk based on their percentage, like their risk that you determined from the model, if they're over 20%, you do annual screening starting at age 30. And this is if their lifetime risk is over 20%. And then you would do annual screening. If the patient has a first degree family member that was diagnosed and they are in this high risk category, then you want to start 10 years before that first degree family member was diagnosed, but you don't need to start before 30. And if they had chest radiation, this is sort of a separate group, not just family related. So if they've had chest radiation, you want to start 8 years after chest radiation or at age 25, whichever one comes later. So now you know when they need to start screening, but then how are we actually going to screen them? So this is where MRIs actually do come into play for breast cancer screening. For these women, they're going to get a mammogram and an MRI each annually, but they'll be staggered by 6 months. So you can do the mammogram and then 6 months later the MRI, and then 6 months later the mammogram. The breast MRI for these patients who are higher risk, when you add the breast MRI, the studies have shown that the sensitivity is actually so much greater. Without the MRI, if you just do mammograms for for high risk, it's between 25 and 60%, but it increases up to 75 to 91% if you add breast MRI with mammogram. Okay, so that's high risk. And then another thing to think about with high risk patients are just the fact that they may be eligible for prophylactic medication. We won't go into a whole lot of detail about this, but this just includes things like taking tamoxifen, raloxifene, or any aromatase inhibitor. And if you have a patient who fits into this high risk category, if you can, of course, if you're here in the UW system, you can think about getting them a consultation with a breast specialist, just because they might be able to talk through what kind of medications would make the most sense for them. Okay, so let's go to our biggest bucket now, which is going to be average risk women, or average risk patients, I should say. So if patients are at average risk, then we want to give them guidance on how often they need to be screened and what type of screening. The people that are going to fit into this category, and again, this will be our biggest group, it'll be people with no gene mutations, they've had no cancers, they've had no known high-risk lesions, they don't have anybody with first-degree breast cancer, they have radiation, and then once we do their scores, they're going to be under 15% for lifetime risk and under 1.66% for 5-year risk. So once we decide that they are in this category, we have to decide how and when we want to screen them. So your patient comes in and says, my friend's been getting mammograms since she was 40, but I haven't had any mammograms and we haven't talked about it. So this is where all of these different societies and guidelines comes into play. So these are a list of all the different groups that have put out recommendations for breast cancer screening. As you can see, there are a lot. They differ. The things that differ the most are really the age that they start, and then how like the frequency that they're screening. So annually versus every other year is really the difference. There are a number of different groups that you can follow. I think an important thing to think about is just if patients have really strong feelings about wanting to start at certain times, you can probably find a group that would be in support of that time frame. So it's really, a lot of this is shared decision making, but as people in internal medicine, we tend to follow USPSTF, which is the ACP put out their own guideline, but it's very similar and follows a lot of the USPSTF guidelines as well. So for those, generally they start at 50 and they're every 2 years. And for starting at 40, it would just be a little bit more of a shared decision-making model. So there were randomized control trials that found screening every other year still reduced breast cancer mortality, but that it ended up reducing, it had improved rates for false positives and extra biopsies. So the general sense was that every other year screening, you still got most of the benefit, but you had less of the harms. There has been some back and forth discussion about annual breast screening for high density breasts, but at this time, there's no great consensus around that. So when you're thinking about these things, if you are talking to women about when they want to start and how often they want to do this, if they are just kind of looking to you for guidance, you can go off of one of the society recommendations, that's fine. If they have feelings about when they want to start or what they want to do, it would just be important to talk through, weighing these risks and benefits and thinking about the fact that, the benefits, of course, that you have early detection, you might have less treatment, you may reduce their mortality from breast cancer. For some people, that might reduce their anxiety to start earlier. For other people, it might increase their anxiety to start earlier because now they have more information or they have to end up getting a biopsy. There's pain and stress involved in some of these things. And of course, there's cost to consider as well. So just a lot of things to weigh, but it's really important to just talk through and come up with a plan of what they are most comfortable with. Okay, so this patient comes in to my annual exam done. I've had a lot of patients asking about, and these are the things that we were talking about in the talk, clinical breast. So breast exams are really important for somebody with a breast symptom, like if they now, can you hear me? The technical difficulty. I'm unmuted by my host. Okay, now can you hear me? Okay, that was very strange. Zoom just like completely shut down on my computer. Okay, clinical breast exam. So yes, if anybody has a symptom or an abnormality that they are worried about, absolutely
Hey,
do it. Yeah.
We don't actually have your visual of your screen, so I'm going to let you share the screen to you again here.
Okay. How about now? Yes.
Yes, much better.
Okay.
Sorry, everyone. No idea what Zoom just did there.
I don't know what
it seemed to time out for all of us.
Okay, so everyone can hear me and everyone can see the screen? Yes. Okay, cool. So I think just to put this point home again, I think if patients are coming in with concerns or symptoms about their breasts, if they felt something that's abnormal, their nipples are abnormal, like anything like that, always, always, always do a breast exam. That is always a time to actually do a physical exam. However, for just annual screening or just thinking about breast cancer prevention, it's actually the studies have been pretty unclear if this actually needs to be a part of it. There's been some studies that have shown that it ends up causing more and more false positives, but there's not a great amount of evidence that shows it actually has any benefit to screening. So I think, it's, if people are really wanting it, it gives them peace of mind, that's fine. But I think I have sort of personally had my practice to just tell people that, it's not really something we need to do unless they have a symptom. And then similarly for breast self-exams, this is something I think that used to be really commonly, promoted to women to do their own breast exam at home. There have been, the studies have shown no benefit from this. It's actually caused, again, sort of similar to clinical breast exam. There have been studies that have shown that it has increased the amount of biopsies done and not actually improved a lot of breast cancer pickups or mortality. So I think the thing to do is they're trying to promote breast awareness. So just encouraging women, they don't need to do their own breast exam all the time, but just sort of knowing what their breasts look like, what they feel like, where different, if they do have, kind of one breast looks different than the other, just knowing what is normal for them so that they can pick up when things change. Yeah.
Maybe you mute so that they don't get
okay.
feedback.
Addie has a point.
I just want to make a couple points about this. One, Tessa's specifically talking about women who are average risk. And so if you have a patient who is asking about a breast exam and has a first-degree relative with breast cancer, she's probably not actually part of this group that we're talking about. And so I would be mindful of like a blanket no breast exam policy, because that's not really what the guideline is. It's, you need to talk to your patient, find out what you think their risk might be. And you don't need to go through a whole risk calculator, but you can use some guidelines like first and second degree relative, history of an abnormal biopsy, all those things take that woman out of an average risk category. And so then the decision about a breast exam is a little bit different. And you're going to be thinking a little bit more some of the other guidelines that offer a guideline for that person. So keep that in mind. And then also, I think as an institution in our primary care practice, we follow USPSTF, and this is definitely their recommendation, but be mindful of the fact that not all societies recommend this. So just like with prostate cancer screening, USPSTF has sort of like a clear guideline, but other societies are different. Just keep in mind that you are following that guideline, and that is not necessarily the guideline of all societies. And so I think just having in mind that if, for example, from a medical legal standpoint, you would want to be clear that that's the guideline you're using and why, rather than just sort of explaining to a patient that there's a blanket guideline against breast exam, because that's not quite the case. So.
Thanks, Addie. Awesome. Cool. Any other questions there? No. Perfect. Cool. Thanks so much, Addie. Okay, so so that was all focused on average risk patients. So we've talked about high risk, we've talked about average risk, and then of course there's always the gray zone. So what do we do with these patients who are these intermediate risk group? So most of the time, I think people will end up in the intermediate risk if we've, done their scores and they're between this 15 to 20% lifetime risk, or their 5-year risk is in that middle as well. And, I think if we are thinking about patients in this group, it can be a little bit harder to know exactly what to do. So I think the emphasis from all the things that I had read through about this group is really just thinking about shared decision making. So, you can look at the average risk recommendations and then think about, what maybe makes more sense for this patient. If we know that they have a certain family history, or we know that their lifetime risk is slightly above average, do we want to start earlier, USPSTF says that if they have, slightly more than average risk, we can consider starting at 40. And that's why that piece in their recommendation said starting at 50, but consider on an individual basis from 40 to 49. So this is one of those situations where you could start thinking about screening earlier if patients were open to that. Usually, I think most of the organizations have said annual over biennial screening for this group as well. And then a couple other pieces to just keep in mind that if their intermediate risk is based on family history alone, like if that's really the only thing we know about them that puts them in that category, there's been insufficient evidence to show anything specific about MRI inclusion for this group. It's not that it isn't a good idea. It's just that there hasn't been enough evidence to show anything for or against it. So at this time, it's not recommended. If they have intermediate risk based on breast density, then those, in that case, there has been more conclusion about the fact that they do not support routine use of MRI or ultrasound for additional screening. So just a couple details about, we talked about these people who fall into the high, intermediate, and average risk categories, but then, there are a few different special populations we might want to think about. So for high density breasts, I think we spoke about this a little bit earlier, but for patients who come in worried about their breast density, if they've been notified about that, it's just important to emphasize there is no recommendation at this time for additional ultrasound or MRI if they still fall into that, if they are still not a high risk individual. There is a recommendation though that they are better off getting a digital mammography, and most of the time, if you are ordering a mammogram here in the US, you will be ordering a digital mammogram. So you don't need to worry that you've maybe been ordering the wrong one. There are very few film mammograms done here, but ordering a digital or the 3D digital tomo mammograms are the best things for these high density breast exams, just because they get a better picture. But for high density breasts, you could consider annual over biennial exam. This is again, maybe one of those cases where they fit into that intermediate group, and they might want to just do an every year versus every other year if that gives them peace of mind. Other populations to consider, so people who've had breast implants, and this is not talking about people who have had breast implants or reconstruction after breast cancer or breast cancer surgery. That's a whole separate group of people. This is just people who have had benign breast implants. They still need to be screened. Just because their breast anatomy has been changed does not mean they don't fit into a screening protocol. They need to have regular screening. They go the same stepwise approach that we talked about, and not really for our worry, but more for the radiologists. They will just get different and additional views. So people who have had breast cancer themselves, they are of course at higher risk. However, they kind of fit into a slightly different timeline. So based on how long ago they were diagnosed and where they are in their therapy and post-therapy, they will have diagnostic mammograms for a certain period of time, and then will eventually maybe return to surveillance or screening mammograms. But I think, these patients are slightly out of the scope of this talk, but they are going to be people you want to have high alert with and just develop a really good survivorship plan with their oncologist. And then finally, patients over 75. So a lot of these guidelines do offer some insight into when they think you should stop screening. The age that you stop, a lot of them recommend age 75. However, you really want to think about shared decision-making with these patients as well. So if they, if they're getting to that age and they're asking about their screening, you want to just consider what their overall health is, and maybe consider stopping when their life expectancy is under 10 years, just because the risk and benefit ratio for something like breast cancer screening is really only appropriate to weigh when they have, a longer period of time to potentially gain that benefit, whereas they may have the risk and harm of needing biopsies or something sooner than they actually might see that benefit. Okay, so just a couple other little tips to keep in mind for when you're actually talking to your patients in clinic about their mammogram. So say that you've done your great stepwise approach, you put them in the right category, you've got them, decided into what risk they fit, and now you're ordering their mammogram, and you want to know, what do I actually tell them about, when the people are going to call them and schedule them? I think it's important to just tell patients that the mammogram is radiation, so it is an X-ray essentially, and that there will be breast compression. I think a lot of patients sort of know that, just sort of like, from community-wide understanding of what mammograms entail. But I think just saying up front, especially if it's their first time getting a mammogram, that it is going to be painful. It's brief. There is breast compression, but that is actually, the compression is because they're trying to get a better picture. Just explaining it might be helpful. And then also, if patients are scheduling their mammograms and they are still getting their period, it might be helpful to advise them to schedule away from times that they're actually, that their menstrual period is happening, just because the study itself is less sensitive and it can be more painful. And then another thing to keep in mind is that repeating the mammograms at the same location, if that's possible. Of course, it's not always possible if people move, but if they always get their screens done at a certain imaging center here, it's good to just keep them going to that same place. Or if they can bring old films or old images, that's really helpful, just because if they have an area that was being monitored, or that was something that people were watching earlier, it would be really helpful for the future radiologist to see what the before and after picture was. All right, so just to wrap up with some conclusions, I tried to put all of our little boxes into one slide here. So let's just go to this one. So just to review, this stepwise approach to thinking about breast cancer screening with our patients who are sitting with us in the primary care office. The first thing is going to be getting a family history, and we can use those tools from USPSTF or NCCN, and those tools can help us get all of the details we need for an actual thorough, appropriate family history. If they do have any concerns or risks with their family history, then we would want to refer them to genetic counseling. If they don't have any of those things, if they don't have family risk, then we can move on to assessing their personal risk. When we think about their personal risk, we get all of those details about hormone history, their age, their weight, their own biopsy history. And if they fit into any of these concerning categories like the ADH or LCIS or chest radiation, those patients immediately go to high risk. Otherwise, if they don't have details, then we want to move on to picking a risk prediction model. Just emphasize again, the BCSC and the Tyrer-Cuzick model are the more commonly used models in primary care. BCSC is great if patients are really worried about breast density. We can add that detail in. And then the Tyrer-Cuzick model is the slightly more cumbersome, but also super, super important for patients who have very complex family history. And then once we go through those models and we get an actual 5 or 10 or lifetime percentage risk for breast cancer, we can put our patients into one of these average, intermediate, or high risk groups. And so once we know which group they're in, if they're average, we will generally be following the US PSTF guidelines, which is the ACP, similar to ACP. But of course, shared decision-making, always a key piece of that. If they're intermediate, really, really focusing on shared decision-making and maybe just modifying slightly the timing and age that you start for the average risk timelines. And then for high-risk patients, want to think about the annual mammo and annual MRI, each staggered by 6 months.
John Cho has a question.
Oh, yeah.
It's just asking, how long does it take for you to go through all of this in a patient visit?
I would say this requires its own visit, John. And what I do when someone has questions about their risk or wants to talk more about it, I recommend a separate visit. For that reason, it does take time. I think when you're in your annual visit, if that's something that you're doing at your clinic, I don't know how many of those I did as a resident of adult med, but if you are in a chance to sort of discuss screening, I think you can always spend a minute talking to them about their family history as part of your shared decision making that you've always done, about whether they want to start at 40 or 50, and do they think every year or every other year is more to their preferences. And then you can decide whether or not, even in a gestalt, whether or not they are someone who might benefit from something different than the USPSTF guidelines. So I think you can have a brief conversation at the moment that you're like ordering a mammogram. And if they want to have a more in-depth conversation, or they have questions about their density and risk or whatever, because people are getting a lot of letters now, I would recommend people come in for a visit specifically for that.
Okay, great. All right, so then just wrapping up, thinking about our objectives again. So we identified the important risk factors for breast cancer. We talked about actually taking a thorough family history. We learned our stepwise approach in developing our screening plans. And then we talked about the risk calculators and which ones are more appropriate at different times. And then we learned how to assign patients to the proper risk categories so that we could get them on the right screening plan. And that is where we'll stop. Anybody have any extra questions?
It looks like Alice and Claire have a question about
so
trans women and trans men.
I think I'm not muted. Okay, great. So there was a question about screening for trans women and trans men. And I think I don't have a great deal of expertise on that, but I would say that I think for most cancer screening, we tend to try to ask patients, which body parts they have. And so if they still have breast tissue, then I would imagine you'd still want to walk through these steps and think about where they would fit on these average risk categories. Let's see, I think Nina and I are pulling up the UCSF transgender care. And just to throw that out there, as I'm reading it, but just if people want to, I'm going to look through this a little more later, but it looks like this is a good resource for answering that question. But I think that, I would just try and focus on if they do still have breast tissue, then it would still be important, no matter where they are on the transgender place, that you would want to make sure that you're screening them.
Yeah, I don't think there's any data to guide that decision. I would say that especially for trans men, that like Tess said, if there's breast tissue remaining, to definitely consider it, or just, discuss it with them again. If that's something that's traumatizing to consider, then of course that's their decision, but offering them the information that as long as they have breast tissue present, there could be a risk of breast cancer still. And in that vein, I would add that there are some people, endo at the VA recommends 5 years. Okay, that's helpful. So Megan Rochester said, for trans women who have been on estrogen for 5 years at 2 milligrams daily, they would recommend mammogram from that point onwards. So great. The last point I just wanted to make about trans men is that there are different degrees of mastectomy. So it depends, depending on his risk, you may still want to consider, even if they've had a mastectomy, if it was really like a radical mastectomy, or whether it was something more for cosmetic reasons and certain parts of his anatomy were retained. That would also influence the decision about whether or not to pursue mammography. So just like everything else, lots and lots of shared decision making. I think breast cancer screening is getting complicated, but there are some sort of like ways to frame what you do and use a stepwise approach to help you do that.
Okay, I don't see any extra questions on there, but thank you. That was a great question. And thank you, Megan, for the tips from the VA. So I think we'll end there, and I don't know if we'll take a break before Nina starts.
People need a bio break.
Yeah, we'll take a quick few-minute bio break while we get this set up on Nina's computer.
When should we resume? Should we resume at 10:05? Is that what?
Sounds like a great plan.
10:05. Okay, we'll get started at 10:05.
No line for the bathroom.
2 minutes.
Hey, Nina, do you want to try and get your screen share going? Sarah, I don't know. Do you have to give privileges to Nina to let her share her screen?
Nope.
Oh, there.
She's getting it set up.
Cool. I'm just gonna flip through these in case.
Nina, do you want to check your audio too to make sure that's working?
Can you hear me now?
You are very quiet.
Oh. How about now?
Pretty much the same. Are you doing it through headphones?
No, it's through my computer. Let me try.
Okay.
Because my computer is a little bit old.
Yeah, right now I can barely hear you.
Okay.
Are you trying to switch to Tessa's computer?
Testing.
Was that you, Nina?
Yes, can you hear me?
No, not at all.
Okay, I'm gonna switch to Tessa's computer.
Okay.
Hi guys, sorry for the delay. I am just going to quickly click through these slides to see if everything's looking okay before we get started.
Your audio is much better.
Okay, great. Okay, so Zoom is saying that I'm Tess, but obviously I am not Tess. I'm Nina. I'm one of the R2s for those of you I haven't met in the primary care track in the Women's Health Pathway. So I am going to be wrapping up our Women's Health academic half day with a talk about contraceptive counseling and prescribing. Oops.
I renamed you, Nina.
Okay. All right, so roadmap of what we're going to talk about today. We'll start with some objectives, go through a framework for contraceptive counseling, talk about types of contraception, and then talk about how to safely prescribe contraception. We'll talk a little bit about troubleshooting. So for example, if patients come in with side effects that are intolerable, how can we kind of troubleshoot the doses of hormones in their contraception? And then we'll have a summary. So some of the objectives for my talk today, by the end of the talk, hopefully we can identify a patient's reproductive and family planning goals, learn some of the different types of contraceptive methods, guide a patient to a decision about contraception based on their goals, and then also apply some evidence-based guidelines based on the CDC medical eligibility criteria tool. That's an app that's available. So just to sort of set the stage in terms of some of the basics of contraceptive counseling, just what are some times that are appropriate for contraceptive counseling? I think during an annual wellness visit, it would be very appropriate to bring up contraception and reproductive life goals. It can also be sort of a problem-focused visit if it was patient-initiated or if you just didn't have time to get to it at an annual wellness visit, for example. When you first meet the visit, they fill out a lot of paperwork, and usually there's some questions about contraception or pregnancies, that kind of thing, which could be a good segue into discussing that. Maybe you talk about it over the course of a couple different visits if it's more of a, if the patient has a lot of questions and wants to think about things. But really the point here is that we can discuss it at any visit. And hopefully this talk will give you some tools to feel comfortable talking about it with patients at any visit. And another point I want to make is that contraceptive counseling is appropriate for any patient of reproductive age, regardless of gender identity. Obviously, there are sort of male-directed and female-directed options, and I think it's important to talk about it with everyone who's of reproductive age. So to start off, I sort of put together a framework for contraceptive counseling. This is how I think about it. The thing that I want to highlight is that it's really based on shared decision-making. This is obviously, it can be incredibly sensitive and sort of an intimate thing for a lot of patients. And so giving them as much autonomy as possible, especially if they're the kind of patient who maybe prefers that type of autonomy. And just in some of the data with shared decision-making, patients were more likely to be satisfied with their counseling when they perceived that there was shared decision making, and also felt that they were more satisfied with the contraceptive method that they chose, and were more likely to continue with it. So some of the other things to think about would be patient-centered factors. So what are their preferences? For example, have they heard about different contraceptive methods before? Have they tried different things? What have their friends told them? What is their intention in regards to pregnancy? Do they think that they want to get pregnant ever? And if they do, what's sort of their timeline? Do they have a timeline even? And then also thinking about some medical factors. So thinking about what types of contraindications may they have? What types of comorbidities do we need to watch out for? What are some of the drug-drug interactions that may reduce efficacy of contraception as well? So I'm going to focus first on the patient-centered factors. This is a nice graph with data from the CDC. Between the years of 2010 and 2017, women between 15 and 49 years old and their pregnancy intentions. And so intended pregnancy is where they, had planned the pregnancy and they wanted to have the pregnancy. So that's about 63% of pregnancies. And then mistimed means that they want to get pregnant at some point, but maybe it was not quite the right time for them. So that's about 23%. And then pregnancies that were just never, that patients didn't want, that makes up about 14% of the pregnancies in that time. And this is data from a huge national survey that they did called the National Survey of Family Growth. I think it was like multiple years across the country, I think tens of thousands of patients, with really in-depth interviews. Okay, so in terms of thinking about how we talk to patients about their reproductive goals, there's a couple of big buckets. One is using open-ended questions, and I've provided some sort of scripts, I guess, or questions that you could lead with. For example, what are your thoughts about becoming pregnant now in 1 year or 5 years? And sort of some motivational interviewing as well. What are you using to prevent pregnancy? Or what do you plan to use? If they say that they never want to get pregnant, then asking them, is it possible that you could that might change at some point, or that you and your partner might have a different opinion in a couple of years. Some specific questions. There's a couple different scripts out there. I'm going to highlight this one called PATH, which just stands for pregnancy attitudes, timing, and how important is prevention to the patient. So thinking about, do they want to have children or have more children at some point? When and how important is it to prevent pregnancy until then? Because there are some people who maybe contraception or preventing pregnancy isn't necessarily one of their priorities, and they would welcome another pregnancy even if they're not necessarily planning for another pregnancy. And then lastly, I think most importantly, to highlight that it's important to avoid assumptions. So with pregnancy intention, I think unfortunately the language is sort of problematic because it makes it seem like it's a binary thing where things are either intentional or unintentional. But there are plenty of patients who, exactly as I described, maybe don't necessarily plan to get pregnant, but would be happy to keep a pregnancy if they were to get pregnant. And there's a lot of complicated, factors, and it's not just a sort of yes or no answer to that question. There's a lot of obviously life factors, social factors, financial factors that go into their decisions as well. And so as much as we can, helping them to guide their decisions. And then thinking about what their priorities for contraception are as well. I think, especially because most of our data is based on effectiveness of contraception, and that's how we measure a lot of our milestones. Patients' priorities for contraceptions may be different than what sort of the medical system imposes. So effectiveness may not be the number one priority for all patients. Maybe they really want to avoid having side effects. Maybe they would really prefer to not have to think about it at this time, etc. And leaving room for ambivalence and for dynamic change. Obviously, when we have a conversation with a patient, it's really at that point in time. And so sort of leaving it as an open-ended discussion and question, so that they can feel comfortable talking about contraceptive options at any time. And this is, I just want to bring some attention to some of the ethical practices of contraceptive counseling and prescribing. Just sort of want to plant this as food for thought about how we as providers can minimize our impact on health disparities. I think probably the most effective way is providing non-judgmental, patient-centered care. And really focusing on shared decision-making and providing patient autonomy, especially when it's sort of indicated that the patient prefers that. There are some papers out there that talk about how low-income women of color are more likely to report that they are being told that they should use longer-acting contraception or receive sterilization. And then there was this New York Times article last year that was written by a UCSF clinician and researcher who kind of pointed out that IUDs or long-acting reversible contraception is sometimes touted by governing bodies as a poverty cure. And so, and sort of the dangerous implications of that. For example, there are some community health centers or some governing bodies of community health centers that use long-acting reversible contraception initiation as one of their sort of measures of success. And it just so happens that a lot of community health centers are also in sort of low-income urban areas where there are more people of color. And so, you know, what does that mean when our measure for success is this procedure? Okay, so back to other patient-centered factors. So how do we talk about patient preferences? I think it's important to elicit what their priorities are for a contraceptive method. So leaving things open-ended, you can ask, do you have a sense of what's important to you about your birth control method? Most likely they already have, you know, sort of heard about side effects, or they've thought about, like, you know, they've heard maybe information from the internet or whatever shows that they watch about what is effective and what's not. And then also sort of framing a conversation around the side effects of these contraceptive options and how some of them have non-contraceptive benefits. So if there are other things, for example, if they have acne, or if they, you know, feel like whatever, they feel like they get really bad cramping around their periods, maybe sort of addressing some of those issues with this discussion. So this is just a more comprehensive list of some of the things that we can talk to patients about in terms of what, how we can go through a decision aid with them and decide what would be most appropriate, or what their options would be that would be in line with what they are looking for in a contraceptive method. Okay, so next I'm going to talk about the different types of contraception. This is just another CDC graph that shows the breakdown of the 4 most common types of contraception in the US, based on broken down by age. And so it's interesting just to note that in the older population, it seems like female sterilization procedures, which, you know, for example, includes tubal ligation, seem to have a pretty high rate. And then the pill and long-acting reversible contraceptions are next, and then condoms are the 4th. So different types of contraception. I'm not going to go very much in detail about all the different types of contraception, mostly because there are so many resources that kind of outline the different types, and they talk about the effectiveness and side effects, and there's so many different decision aids, which we'll talk about in a little bit. So I'm just going to sort of do a broader overview of the types of contraception and how, and focus on a couple to talk about how we can prescribe those in the clinic. So with our hormonal options, we think of the pill, and that's both combined and progestin-only pills. And then there's the patch. There's the ring that it's inserted into the vagina. And then there are injections. And then there's the implant and the IUD, which I put together because those both require a procedure. And then there are non-hormonal options. So for example, barrier methods like condom, diaphragm. There's the copper IUD. There are fertility awareness methods, or like natural planning awareness methods, where patients will, for example, keep track of their ovulation and kind of use like cycle methods. And then there's spermicides, and then there's also surgeries. So obviously those are going to be mostly irreversible. There's vasectomies and tubal ligations. So I think one thing that is helpful when thinking about how to talk about contraception with patients is to find a visual aid and commit to it and use it and get to know it. And there are so many different ones out there. And like I said, a lot of them are sort of sorted by effectiveness. But they also highlight a lot of other things. Like, for example, the one right in the middle here, it shows pros and cons that are sort of, you know, not necessarily organized in any manner, but just some of the common things that come up. And this one back here is a little bit more comprehensive. It shows, it talks about how often the method is used, what are the specific menstrual side effects that patients might expect, and then other considerations as well. So I have a list of resources at the end of my talk, and all of them have different types of visual aids that are helpful. I think one thing to consider about choosing a visual aid, though, is how it talks about efficacy or effectiveness, because I think there's some confusing ways of talking about it. So this one on the left is it seems like a pretty straightforward and a visual representation that it maybe is easier to understand than the one on the right. So for example, what is your chance of getting pregnant? Less than 1 in 100 women will get pregnant on this method. That seems pretty intuitive. Whereas when you say how well does it work, 99% of the time, it's, it leaves a little more room for questions, I think. So I'll just put in a plug for that, but just sort of anticipating questions that might come up when in patient discussions. Okay, so back to types of contraception, focusing on the hormonal contraception options. So there are 2 types. There's progestin only, and those include the pill, the implant, and the IUD. And actually all hormonal contraception has progestin, and a few have both estrogen and progestin. So progestin only are those 3. And then combined hormonal contraception, there's a pill version, there's a patch, and then there's also the NuvaRing. So just to talk really briefly about hormones that are used in contraception. So there's 2 hormones. We talk about progestin, and progestin is just an exogenous version of progesterone. It's just like a lab, a chemical version of progesterone basically, and there's lots of different types of it. The effects of progestins are that they suppress ovulation, they help thicken the cervical mucus, and also thin the endometrial lining, basically so that there's no implantation of a fertilized egg. And then some of the side effects that we see with progestin specifically are acne, hirsutism, weight gain, and lowered HDL. And then just to dive into it a little bit more, because this affects how we prescribe things, there's different generations of progestin. So 1st generation through 4th generation, just based on how new they are. Similar to like cephalosporins, they have like increasing or decreasing activity of thrombophilic activity, although it's still pretty small absolute risk. It's thought that the 4th generation progestins are probably more thrombophilic. And then it's thought that the 1st generation progestins are probably more androgenic. And so that plays into account, for example, if a patient is saying that they have got acne and they want to start the pill, then probably would stay away from choosing a first generation progestin method. But it doesn't necessarily increase androgenicity in patients who have like normal androgenicity to begin with. If patients are already sort of predisposed to having androgenic symptoms, then that's when I would use this as sort of like a guide for what I would start first. And then just a note, there's a 4th generation progestin that's actually anti-androgenic. It's called drospirenone. The second hormone that's used in contraception is estrogen. So ethinyl estradiol is in most combined hormonal contraception. I think there's like one other type of estrogen that I can't remember the name of. So again, their effects here are that it helps to inhibit an ovulation. It also helps to make bleeding a little bit more predictable when there's just one hormone affecting the uterine lining. It does make the uterine lining unstable. And so adding estrogen can help regulate uterine bleeding. Some of the side effects associated with estrogen include weight gain, breast tenderness, headaches, nausea, and depression. And here, the doses of estrogen are categorized as low, medium, or high. And again, this plays into how we can adjust the titration of dosages of estrogen in different contraceptive methods based on the side effects that the patient may or may not be experiencing. So some other medical factors to consider while contraceptive counseling is the safe prescribing of contraception. And so I'm going to make a plug here for this CDC app. It has all the data from the U.S. medical eligibility criteria for contraceptive use, and then also the standard practice recommendations. And the MEC is a really helpful chart. This is what it looks like. It's pretty overwhelming at first, but just to break it down, its main
purpose is to describe the safety profile of different contraceptive options based on comorbidities. So the different categories of safety that they have are, for example, one means no restriction, and it's also color coded, which is really helpful. So they really haven't found data that suggests that there's any reason to avoid using that form of contraception. And then 4 is where it's an absolute contraindication. So just to give an example, so for example, they list condition as headaches, and then subcondition, we have different types of headaches. And as most of us already know, with migraines with an aura, combined hormonal contraception is listed as an absolute contraindication because of the increased risk of ischemic stroke. And so it's a 4, and it's in red as well. So this is an app. It's also just a chart that you can look up on the internet and print off if you want to go through it with your patients as well. The app is pretty easy to use. And there is also a World Health Organization version of this that I haven't used as extensively, but it seems to be pretty similar and maybe a little bit more user-friendly actually, but this is the CDC specific app. And then also in the app, so some of the other absolute contraindications, just keeping in mind with hormonal contraception. So in uncontrolled hypertension, so for example, systolics greater than or equal to 160, in patients who have diabetes with vascular complications, in patients who are greater than the age of 35 and smoking equal to or greater than 15 cigarettes a day, et cetera. So because it's color coded, it's really easy to just look through and look for all the 4s on the chart. The other aspect of this app is the standard practice recommendations, which is also really helpful for contraceptive guidance and counseling. So for example, it shows you how to start each of the different types of contraception, and then it gives additional information. For example, clicking on the combined hormonal contraceptives, it talks about how to initiate the contraception, what types of exams and tests might be needed, what kind of follow-up do you need, what do you do if the patient misses a dose or has a late dose, and what are some of the severe side effects, and how might you help the patient deal with those. So prior to prescribing contraception, there isn't too much that necessarily needs to be done in terms of an exam, thinking through like what we do during exam in the HPI and testing portion, thinking of drug-drug interactions. And there aren't actually too many here. Some of the ones to note would be anti-epileptic medications, and then some HIV medications are thought to decrease the efficacy of, potentially decrease the efficacy of hormonal contraception. And then Addie has a note.
About just your last section, since you're kind of moving here. The question was about whether or not the absolute risk is significant enough for most people to recommend against combined hormonal contraceptives. Okay, I can answer it. Do you want to mute you?
Yeah, I think 2 points to make here. One is that you are making the point, which I think is important, that when you look at the MEC or the eligibility criteria, they're comparing the risk compared to no medication at all. And they're not comparing the risk to pregnancy, which is also a highly estrogenic state. So sometimes you do need to consider for your individual patient, for example, someone with like very severe heart failure, that would be a pregnancy could be fatal to them. What is the bigger risk for them? Is it becoming pregnant, or is it being on some form of hormonal contraception? So, I mean, just like with everything, to beat the dead horse, you really have to talk to your patient about what her values are, how she weighs these different things. And I think, again, like from a medical legal standpoint, if you've documented that you had that discussion with her and that this is what the only method that she's comfortable using, I think, I don't tend to personally withhold methods from women who I feel they can participate wholeheartedly in that discussion. And to the point about migraine with aura in particular, the risk is low, but I think the absolute risk remains very low for young women with migraine with aura to have a stroke using an estrogen containing method. But and so I think if, again, like if that's the only method she can use or wants to use, and she feels very strongly that pregnancy is not something she would be comfortable with right now, then I, again, like with documentation of that discussion and with my personal impression that she understood that discussion and can make an informed choice, then I won't withhold it typically. But you do want to recognize that you and she are taking on a little bit of increased risk. Do you have follow-up questions or comments about that? Or anyone else?
Okay, thanks, Addie. Okay. Okay, so prior to prescribing contraception during the visit, I'm thinking about drug-drug interactions. Like I said, some HIV medications, and then the anti-epileptics as well. And there is this myth that antibiotics reduce the efficacy of hormonal contraception, and that's really only true for some of the TB drugs like rifampin, I think. But in terms of other ones, there just hasn't really been strong data that shows that. So that's a question that might come up, and you can also use the MEC to look through. They do list like antiretroviral medications and antibiotics as well. And then also important to try to make sure that the patient is not pregnant. Usually it's a pretty reliable history, but if they've had unprotected sex 5 days prior to the day of the visit, then we may need to recheck a pregnancy test maybe in like a week or so, just to make sure that we're not missing a pregnancy as well. And then in terms of exam, there isn't really anything specific. Blood pressure is helpful, especially if you're going to be prescribing combined hormonal contraception. Actually, that's probably more necessary than just helpful. But then the other two, weight and BMI, may be helpful just in terms of anticipating potential weight changes with various forms of contraception. And then if placing an IUD, of course, doing a cervical exam. So I'm going to focus mostly on the pill, patch, ring, and injections, because those are things that we can pretty easily prescribe in clinic, whereas the implant and the IUD do require a procedure. And so most likely the patient will need to see a different provider for those. So prescribing the pill, I think when we think of prescribing the pill, the main branch point for me is whether to start a combined hormonal contraception or progestin only. And most often I just am defaulting to combined hormonal contraception, unless there are specific contraindications to estrogen, as we just talked about, or like, if they might have a higher risk for VTE events or something like that. My default is combined. And then the next branch point is to decide the dosing of each. And so thinking about the estrogen dose, so going back to the low, medium, and high dose, and then also the progesterone generations. So again, thinking about, what sorts of non-contraceptive benefits might this patient prefer if they were to use like a different generation progesterone. And then as far as the progestin only, of course, we're just thinking about which generation to choose and what dose to choose. And then so going on with the combined, exactly what I just said. So thinking about the different types of estrogen and progesterone, I usually just start with the lowest dose of estrogen, so 20 to 25 micrograms. And then I also just usually start with a second or third generation progestin. That's my default. And then I sort of titrate based on symptoms later on. And then one other consideration is whether to use multiphasic or monophasic. And this just refers to the amount of hormones that are in each pill every day. So monophasic means every day there's the same amount of hormones in the pill. And multiphasic means that there's like changes in the amount of hormones in the pill. So it's really important for them to take it every day and take the pill that's prescribed for that day on that day. And so for that reason, monophasic medications can be used either cyclically, which is where they take the 3 weeks of the hormone containing medication and then have 1 week of a placebo withdrawal bleed. versus continuous, which is where they don't have that week off. They just have they just take the hormonal medication every day. And if people are using continuous forms, we usually recommend that they try to have at least 3 to 4 periods a year to help reduce the risk of uterine cancer. Sorry, of
Only if they're, no, that's, if they're on.
oh, sorry, I'm saying the wrong thing. 1 second, Addie's correcting me.
If they're using a continuous method, there's no reason why they must have a withdrawal bleed. But if they are not on any method at all, so for example, a woman with PCOS who takes no contraception at all, she can do that as long as she has 3 to 4 periods a month. Because if you're not on some form of hormonal therapy with PCOS and you're not having if you have anovulatory cycles over and over again, that's where you run into issues with endometrial cancer or concern for the increased risk. But if you're on the pill, that is doing that regulation for you, and so you don't need to worry. So if you're on a continuous OCP, there's no reason medically why you must have a must have a period. But if you're not on contraception at all and you have less than 3 to 4 periods a year, you should think about giving them some endometrial protection with any of your forms of hormonal contraception. Does that make sense to people? The difference that I'm delineating?
Okay, thanks, Addie. If any questions come up, please feel free to chat. Okay. So a brief overview of how to prescribe the patch, ring, implant, and injection. So the patch, there is only one formulation that I know of, and it's prescribed. So the patient will change it every week and on the same day of every week for 3 weeks, and then there's no patch for the 4th week. This can cause skin irritation. That's one of the main side effects. Other things that are just sort of pitfalls is that sometimes the patch falls off, or if it gets too wet, then sometimes it'll fall off as well. So sometimes they're not necessarily getting the hormonal medication that they think that they're getting. And one thing to note about the patch is that it cannot be used continuously. So it cannot be used in that way where you just continue to have a patch every week. You do have to have that 4th week without the patch. And then the ring, patients can place this on their own, and they just place 1 ring inserted into the vagina, and it can stay in for 3 weeks and then removed for a week. However, this can be used continuously. So if they don't want to have that week without protection, they can just continue using it every week. And then there's the implant, which is the next one on, or the rod that goes in the arm. This can last up to 3 years. This can last 3 years officially, but some research is showing that it can be effective for up to 5 years as well. One of the side effects that can come up with this is that it can cause irregular bleeding. And then another thing is that it has a pretty, that's it for implant. And then the next one is injection. So this is done every 3 months, and it can cause, some of the side effects are weight gain, irregular bleeding, and decreased bone density. But notably, after the patient stops the injection, their bone density goes back, is no longer decreased. Another thing to note about the injection is that there's longer return to fertility, which means that after stopping the injection, it just takes a longer time for a patient to be able to get pregnant if that's their intention. And a lot of that has to do with, you get the shot and it already has a three month duration of action, and then after that, it still takes usually at least another 3 months or so until a patient can get pregnant. Okay, so some of the non-contraceptive benefits to contraception. So specifically for combined hormonal contraception, it can have significant effects on patients' menstrual cycles, so less dysphoria symptoms or less dysmenorrhea. Maybe their uterine bleeding becomes a little bit more predictable. Also in terms of cancers, still emerging research, but it does seem to have reduction in ovarian and endometrial cancers at least. And there's a question about colorectal, even kidney and other cancers. And it can also have benefits if a patient has acne. And then for the hormonal IUD, again with the menstrual cycle, it's pretty similar to the combined hormonal contraception benefits. So can help with dysmenorrhea and irregular uterine bleeding. Also helps to reduce endometrial and cervical cancers. And also there seems to be a reduction in pelvic inflammatory diseases. So next is to highlight some of the troubleshooting that might come up if a patient started on contraception and maybe has some side effects that are intolerable to them. So just to quickly review again, side effects of estrogen include possible irregular bleeding, headaches, nausea, vomiting. Sometimes there's mood changes, there's weight gain. And then for progesterone, they might have increased acne, they might have increased bleeding or irregular bleeding. And so this is a helpful chart just to think through, if a dose is too high, what are some of the things you might expect? And if a dose is lower, then what are some things you might expect? And then this is also helpful in terms of thinking about if a patient is saying that they feel like ever since they started their combined hormonal contraception, they've been having some bloating, for example, then considering reducing the estrogen dose. Or you can try using a formulation that has a progesterone that has like a mineralocorticoid or like a diuretic effect, anti-mineralocorticoid. And then if there's breakthrough bleeding, adjusting the dosages of estrogen as well. So if they're on a low dose, you can go up to medium or high doses. You can also consider changing progestins. And it kind of goes on from there. So there's this is a helpful resource. There's also, like I said, on the CDC NEC app, there's also some helpful guidelines there about how you can troubleshoot symptoms that come up. One big one that comes up is with nausea. If patients take their contraception with food or at bedtime, then that does seem to be helpful for a lot of them. And then also considering reducing the estrogen dose. I want to also just put in a plug for this resource for how to switch contraceptive methods. In general, I would say like the principle here is just to plan ahead by about a week and just plan to maybe need to use a backup method for about a week. This is a great resource that will be linked in my slide set, but it's from the Reproductive Health Access Project, and it lays it out in a really easy to read way. So that's something that you can also go over with patients during the clinic visit. And then as of this year, there are some more official guidelines about contraception in transgender patients. And basically what they know with the very limited data right now is that it's okay to use all forms of contraception regardless of current or prior testosterone therapy. And so that includes combined hormonal or any form of hormonal contraception. Here, probably, as much as in any other visit, it's very important to elicit patient preferences and you share decision-making because some transgender patients may consider, that estrogen and progestin to be feminizing hormones, and they just really want nothing to do with those things. And so talking to them about what exactly it is, if they have, if they want contraception and they have they're not excited about hormonal contraception, getting to know what it is about hormonal contraception that is maybe making them pause. And the caveat here with this data is also that most contraceptive data that's out there is from studies with cisgender women. And so I think there's just a growing body of literature probably, but at this point there's still not very much. And I have the source that talks about this listed on the slide as well. And then just quickly to talk about emergency contraception. So there's three main types. And so this is for use if a patient has had unprotected sex and just wants to try to prevent pregnancy after that. The most effective is going to be the copper IUD, and this, if it's inserted within 5 days of unprotected sex, would be like. And the benefit here is that it can remain in for long-term contraception if that's what the patient chooses as their long-term contraception, if they want contraception as well. And then the two oral options are the Plan B pill and ulipristal, also known as Ella. So Plan B, there's one dose, there's a one-time dose, or there's multiple doses. There's some data that shows that both of these options are less effective in patients who are overweight or obese. And so for Plan B specifically, the data shows that it's less effective in patients who are greater than 165 pounds, and possibly ineffective in patients who are greater than 176 pounds. Another caveat here is that it's really most effective if used within 3 days of a patient having unprotected sex. However, one of the biggest benefits here is that there's no prescription needed. So this is something that patients can just buy over the counter. Whereas with Ella, this is a one-time dose, and it's most effective if it's used within 5 days. So a little bit more of a window there for patients. And also seems to be more effective in heavier women than Plan B. However, also could potentially be ineffective in patients who are greater than 196 pounds. And then one other important thing to note here is if a patient wants to start hormonal contraception, then they should wait for at least 5 days after getting Ella. So heading into the summary here, I hope this wasn't overwhelming. There are so many options, and I often feel overwhelmed by all the options. And I think what's been helpful for me is to just go back to visual aid and a counseling framework, and focusing on shared decision making, and using a visual aid to discuss pros and cons, side effects, efficacy, all the things that patients care about with their medications and their contraception. And using some of those troubleshooting tips as well. So in summary, I already sort of promoted the first point, and then the second one as well. And then third point that I want to make is to use the CDC medical eligibility criteria and standard practice recommendations for guidance about patients who have medical comorbidities, about how to start or switch contraception, what to do if there's missed doses, and then also in general, when prescribing an oral contraceptive with both estrogen and progesterone, starting with a low dose estrogen and a second or third generation progestin, and then thinking about whether the patient would be interested or wants to do continuous cycling versus cyclic. And just some other quick thoughts that I had, just thinking about the future of contraception. There's a lot of sort of chatter about maybe making OCPs over the counter. So there's more and more data within the pharmacist literature about that. Also, IUD self-removal is something that's starting to be studied as well. So removing that barrier for patients who use IUDs. And then also male options. There's a lot of research. There's nothing that I have heard of that is really promising yet, but obviously there's a lot of things that are out there. And with that, these are the resources that I talked about, and the slides will be available, I think, on the internal medicine website. So feel free to use these. There's a couple of resources that have their visual aids in multiple languages. So for example, the Reproductive Health Access Project one, and then there's a couple that have Spanish versions as well. Thanks. Any questions?
All right. If there are no more questions, I just wanted to touch base with our women's health folks.
Maybe just one additional
Yeah,
thing
go
to
ahead.
just point out for, since we're talking about birth control as well, just going back to the breast cancer risk. I think there, before when I had said, does breast cancer have an increased risk for breast cancer? Does hormonal contraception have an increased risk for breast cancer? I think Nina kind of touched on this already, but there are some cancers that it has a reduced risk for, and then others that there's been data that it can increase risk for. So I think when we're thinking if patients are worried about that, I think there are so many factors that go into cancer risk that unless they have super strong feelings about that particular cancer risk for them, then I think we generally don't steer people away or toward various birth control methods based on cancer risk, just because there are so many other things that can be involved in that. And yeah, so that's all I'd say. Yeah, I agree.
Yeah, if I can add to that.
Sorry, geez. Just, I would say that yes, the risk is there. It's probably, like Tess said, 1.2, 1.5 relative risk. And I think 2 points to make about that. I mean, one, that's essentially the same relative risk as being obese or nulliparous or having your children after the age of 30, which basically many doctors do. And lots of our patients too in Seattle, where we have a lot of professional patients. So I think to contextualize it that way is like, yes, there is a risk. It's not much more than many of the risks that we are already living with. And again, like Tess said, of course, if that makes her too uncomfortable, then certainly there's no need to push that method. And the other thing I would say, just as a rule, is that I definitely, while we as docs can really understand the difference between a relative risk and an absolute risk, discussing things with patients in terms of an absolute risk is much more helpful to them and probably the better way to go about things. So, for example, when we talk about density, if you go from one density category to another, depending on, if you go from sort of the middle two, so from scattered to heterogeneously dense, your absolute risk of cancer goes from like I think 8 in 1,000 to like 13. It's really not that big. So just using absolute risk can be very helpful communicating to your patients.
It looks like
you
go ahead.
can try to do that through the Women's Health elective. What I tell people is that is a good time to do that would be towards the end of your training, because otherwise what happens is you become trained or you have some practice. I would not say that the elective is a place where you will definitely leave the elective ready to do that, but you can at least sort of beef up your practice skills, and then as soon as you're out in practice you can continue to use them. And it helps very much to be in a practice where you might have family medicine or OBGYN colleagues that can be there to support you for your first few or for any like difficult insertions. But generally speaking, it's the pathway residents that are getting the most access and can continue to use their skills in their clinic. And so that's really, the pathway is probably the best way to have the highest chance of being trained when you leave. After residency, I don't know as much. I mean, I guess I will say I did get trained after residency by attending the OBGYN intern procedural training that they offer. And there are often a few attendings there. And then, like I said, I had a lot of support in my clinic from my colleagues who do them all the time to be able to help me until I felt comfortable doing them myself. And so I think it is doable. You do have to be pretty dedicated, and it's definitely going to be kind of like your own, you kind of have to like figure it out on your own, which sounds terrible. I'm sorry, but you have to be committed to that process and then have some support probably. because the nuts and bolts of the insertion are very easy, but the challenges around sort of like the mechanical memory and the visualization and the troubleshooting things like a tight internal os just require practice and comfort. As internists, we're not comfortable sticking like surgical instruments anywhere in a person, so it takes some time. And you're free to email any of us questions that come up. A lot of what Tess talked about is going to be available in a paper that I published with Mary Leigh and Anna Golub soon. So if you want, that'll be available in May through Mayo Clinic Proceedings. And if you want copies of that for your own reference, we're happy to help you get some of those too.
Any other questions from the group before we
Thanks,
wrap
everyone.
up?
Thank you.
All right. Thank you, Women's Health Pathway folks. You are wonderful. And I hope the rest of you guys have a good afternoon. There will be a recording of this that I will email out shortly.